introductions.
Sounds good. I'm Scott Fuller. I'm the Director of Admissions at Fusion Academy here in the Houston Galleria. We're a school that does one-to-one student-to-teacher ratio schooling, completely personalized, and really get to give kiddos the opportunity to have their education kind of tailored to them within state standards, of course. And we do rolling admissions, so we're always taking on new kiddos. So if you have any students that you work with, send them our way. And either way, would love to connect with everyone that's here. And so I'll drop my info in the chat, and I can pass it off to either Julie or Pam, whoever's next.
Go for it, Pam.
Okay, I'm Pam Esser. I'm Director of ATA Southern Region. We work with those with ADHD and coexisting conditions. We do 4 to 5 virtual free support presentations per month. And this month, we're proud to say we're having a live in-person event on Saturday, neuroscience for the neurodiverse. We'll have vendors, sponsors. It's at Monarch School, and I will also drop that in the chat. So check us out.
Julie?
Hi, everybody. I'm Julie Pomerantz. I'm with the Hub Houston. Hub is an acronym for Heard, Understood, Believed in. And we actually offer 4 different programs. One of them happens to be a school. For all of our programs in school, we do work with those on the autism spectrum, those with anxiety, perhaps small depression, ADHD, Down syndrome, etc., neurodiverse. So first of all, we have a school for ages 13 to approximately 18 or 19, depending on how long they need to be with us. It is a very small school. We intentionally keep it small so that we can really get to know these students and work with them and their families. And then we have another campus called Life 101. That is our young adult population, 18 and over. It is an employability program. We're also just working with them on their day-to-day journey through life, helping them with this new young adult stage that they're in, but mostly trying to help them gain meaningful employment. We also have Club Hub, which is a social club for those who are 18 and over. And again, it's just helping them build relationships, friendships, helping them really embark on that social journey, if you will. And finally, on another campus, we have Aspire Accessories, ages 18 and up. We refer to the members there as artisans, and they are creating beautiful items that are sold online and at markets. We actually pay them for their beautiful work. So that's just a little bit about the Hub. I'm happy to see you all here today and look forward to this topic.
Thanks, Julie. Hi, everyone. I'm Alexandra Roark, and I'm here with Dr. Ron Swatzyna. I'm the assistant director and therapist, and he's the director and a therapist here at Houston Neuroscience Brain Center. And here we do EEGs and QEEG brain mapping to look for neurological causes for symptoms. Our team of neurologists specialize in this, and they create an EEG report that helps us create an individualized treatment plan for any age. We see littles all the way up to older adults. And we believe it's important to look for the root cause of the issue. And so we do this by starting to look at the brain. And then based off of the individualized treatment plan, we offer neurofeedback training, red light therapy for the brain. We have EMDR services and other therapy services. And so if you want to learn more about what we do, we have a lunch and learn coming up on Tuesday, May 21st from 11 to 1 p.m. And we have another discussions with Dr. Ron coming up in May on May 15th from 12 to 1 p.m. Central Time. And so I am honored to introduce our guest speaker today, Jessica Ure. Jessica has nearly 20 years of experience working with neurofeedback in her practice, and she's attended over 30 neurofeedback, EEG, and QEEG continuing education lectures and training courses since 2004. She earned her master's degree in mental health counseling from the University of Virginia in 2007 and become a licensed professional counselor in Virginia in 2009 and is certified in neurofeedback and biofeedback through the BCIA and QEEG through the IQCB. She's the co-founder of the Virginia Center for Neurofeedback, Attachment, and Trauma, and we are really excited to hear what she has to say today. So, Jessica, I'm going to turn it over to you.
Thanks, everybody. Thanks for having me. The talk I'm giving you today is about some of the neuromarkers or brainwave patterns that we tend to see in people who exhibit some of the characteristics of autism. And this talk is designed for neurofeedback practitioners, and Ron gave me a whole like 6 days notice on this talk. So I did not tweak it to not be for neurofeedback folks, but it's fine. We're going to roll through this. I think it's still going to be really interesting for you guys. And I'm going to stop so you can ask questions if you want. And I think this will give you a kind of interesting kind of look into how neurofeedback providers may be working with these individuals. So I'm going to share screen here. Just a second. All right, can you see my slide? Awesome. Okay. So we're going to go through these neuromarkers, and we're also going to talk about a case. So there are 6 main patterns that we tend to see over and over again in autistic people. And we don't just see one per individual. We may see multiple of these in the same person. And so they're the 6 listed, and we're going to go through each one individually, and then we're going to do a case study about a 20-year-old male who I've worked with and share some of his findings and how I worked with him. I will say in my practice, I tend to see a lot of young boys between the age of 7 and 9. Tends to be my biggest population that comes in. I've looked over the years, over many years of practice, at kind of the distribution of the population that I see. And in fact, this presentation today is squeezed in between 3 such boys. So this is a population I have worked with a lot. So the first thing I kind of want to talk about a couple of different ways that we look at autism and mental health diagnosis in the neurofeedback world and the QEEG world. We are not so much attached to the DSM. In fact, we really find it, just as Tom Insel does, to be at best a dictionary. It has a set of labels and it defines those labels. And this quote by Tom Insel from 11 years ago has really, all of us have noticed a big shift in mental health since this statement came out, and it continues to shift. And we're really looking for objective measures when we're talking about people's health, and objective measures that can be used in research. And this is starting to penetrate the mental health world. So this is very important. And I'm not going to read all of this to you. You can kind of take a look. But basically, it's just saying, let's move on to something more valid than the DSM. Again, the DSM and the ICD are dictionaries. They describe these clusters of clinical symptoms. And here's a quote from Yuri Kropotov, who has written this book. He's done a lot more than write this book, but he wrote a book called The Functional Neuromarkers in Psychiatry, and he is a world-renowned researcher in the field of EEG. And he says a single diagnostic category represents heterogeneous condition in which similar symptoms may be caused by different sources. So just in all other fields of medicine, we use objective lab markers to diagnose illness, and we're looking for the cause of the symptoms that then can lead us to effective treatments. So an example is an EKG versus an EEG. If someone goes into the hospital and they're complaining of arm pain and chest pain, the doctor is not going to sit down and do a 2-hour interview having them describe in detail exactly what that pain is like in a subjective way. They're probably going to do some testing. And they're going to look at the organ that they suspect is related to the symptom the person is having. Whereas with symptoms that may be coming from our brain, a lot of times we're just pending on subjective descriptions only. And we really want to move that. And Ron is doing so much in work in our field to help move that so that we're doing more testing of the organ that is related to these symptoms. So you all know what autism is, how prevalent it is, the early signs and symptoms. We're not going to go over all of those things, but I did want to emphasize that this talk today is still from a pathology paradigm because I am a clinician and that's where I have come from. However, I'm educating myself a lot recently on the neurodiversity paradigm and learning to change the way that I speak and talk about people who are neurodiverse, particularly those with autism or autistic people, and recognizing that they have strengths and special talents, and just wanting to like also acknowledge that while we as clinicians oftentimes see people who are really struggling with some symptoms that are impeding their ability to live their life in a way they want to, that there are also a lot of really unique and special things about people with autism. So getting down into the meat of my talk and talking about looking at patterns via neuroimaging. There's all kinds of different kinds of neuroimaging, MRIs, SPECT scans, diffusion tensor imaging, and EEG. So I work with EEG, but there are all these other ways of looking at brain activity that may be looking at water molecules in the brain, blood flow in the brain. So they help us to identify objective patterns of activity in the brain. And then these patterns are being correlated with disorders and diseases because we see them over and over again with the same kind of clusters of symptoms. And they've all provided evidence for a neuropathological basis for autism. This allows us to guide our treatment based on these structural and functional measures of the brain. Anatomical, structural changes, there may be parts of the brain that tend to be larger or smaller with different disorders or diagnoses. Neuronal functioning, the actual, like how much activity is happening in different areas of the brain. And then psychological functioning, so matching all of that with behavior. So researchers have noted that many of the patterns associated with autism overlap in people with autism. And so most people's brains reveal a combination of findings. We're going to talk about the 6 main phenotypes or neuromarkers that we see. But just again, we may see more than one of these and often see more than one of these in the same individual. So the QEEG is a quantitative EEG, and that's where we are doing quantitative analysis of the EEG data. And that's measuring abnormalities, instabilities, or lack of proper connectivity through analysis of the frequency, amplitude, and coherence measures of our brainwave data. So that data is compared to data from an individual is compared to a database of many, many, many other people. And so we get all of this, these metrics that tell us where a person lies on these different bell curves, basically, of expected activity in different ways. Also, the what we call the raw data, which we have neurologist friends who kind of scoff at this term, but when we get the squiggly lines, we can have neurologists who are trained to look at those, evaluate them, and screen out for seizure disorders or other neurological issues that need medical attention in a different way than we will treat. So the QEEG results can potentially be used. Obviously, Ron works a lot with this to choose appropriate medication, to look at how the medications that a person may be taking are affecting their brain, if those are a good fit for them. And also they're beginning to use quantitative EEG data to guide the magnet placement in TMS. So again, the power of these neuromarkers, they help us, they aid, they support in making the correct diagnosis. They're not diagnostic in and of themselves, but they can be supporting evidence. They can help provide early detection of brain dysfunction. Some of the research showing how a 2-minute sample of your EEG, I know that the South Korean database, iMedisync, has done some amazing research with early identification of risk factors in your brain patterns related to dementia. And they can see brain changes 10 years before there's any kind of cognitive or behavioral sign. So this is incredibly valuable and important, and I think moving forward will help us to be much more proactive in how we're treating the brain. And these neuromarkers allow us to develop optimal personalized treatment protocols and, as I said, preventative interventions. They also allow us to monitor the outcome of treatment in an objective way. If we do the test before we begin, then we do neurofeedback and we see the subjective changes in reports from the client or their family. And then we can retest and also confirm objectively that we see changes in the activity. The Human Connectome Project is a really interesting, this is a really cool website. Unfortunately, some of the visuals on their website don't work because they involved Flash Player. I don't know if they've updated it, but they have images, DTI, diffusion tensor images of all the brain networks, and they're really beautiful and fascinating. And also Daniel Amen's clinics have a lot of great images, and I'm working on getting permission from the Amen Clinic to use one of their spec scan images in this presentation. But if you go to the amenclinics.com, they have a lot of great images on their site showing activity patterns in the brain through that type of imaging as well. I'm just going to stop for a second and see if anybody has any questions so far. Cool. All right. So again, I mentioned that QEEGs are used for all these reasons, to look at all these various metrics in the brain and come up with basically a cohesive story of what's happening in a brain and how that relates to the symptoms and presentation that a person is coming in with. TMS, I'm sorry, I gave a lot of my talk without going through my slides, apparently. So I wanted to mention in relationship to TMS, and on the left is a sample of what we may do, and this was something that Jay Gunkelman was doing for a while, I don't know if he still is, where he was making recommendations for the strength and placement of TMS magnets based on quantitative EEG findings. And so there's a great memoir called Switched On. If you haven't read it, it's a really great read. John Elder Robinson went through a clinical trial for TMS for people on the spectrum, and his experience with how that changed his perspective on himself and the way that he interacted with the world was very, very interesting. And out of that clinical trial that was happening, there came a big movement within the autism community to push for more research in using TMS for autism. And the Clearly Present org, I haven't checked in on them recently, but they are an organization related to advocating for that. So there are, this talk is basically based on this article, New Brain-Based Individualized Evaluation and Treatment for Autism. And this was written by a group of folks, including one of my mentors, Jay Gunkelman. And they do such a nice job of summarizing the endophenotypes or neuromarkers that we see in autism. And at that time, we were also using the term Asperger's. I know that that is very not used anymore. I just recently learned that he was a Nazi who was torturing children. I did not know that. So I think that's a big reason that we're not using that term anymore. So there's a book that my colleague is reading right now called Autistic Masking. It came out last year, last fall. It's by Amy Pearson, and she goes through. She talks about the history of autism and how it was kind of identified and named. And I think in that book is where Robin found the information about the scientist named Asperger, who was a bad guy. He's a really bad guy. So that book, she said, is really, really awesome. So I'm excited to read it. I haven't gotten my hands on it yet, but I thought I would pass that along. Hot tip. So again, this article is a little dated, and then it's talking about the spectrum in a different way, but the actual content of the types of brain activity that we see, not outdated. So we're going to start going through the 6 patterns, and the first one we're going to talk about is the paroxysmal EEG. So this is also known as epileptiform activity. Another way you could think of it is as subclinical level seizure activity. So this is not a seizure where you might see someone flail around on the floor or have even like an absence seizure where they're just staring. This can be something that's occurring that you can't notice from the outside in an overt, typical seizure-like way. The incidence is approximately 30 to 40% or as high as 70% in the autism community. So it ranges depending on the study you're looking at. It is becoming more accepted for autistic children who do not have documented seizures, but who have paroxysmal brain activity. Again, somewhere maybe as close as 75% of them, to be given a clinical trial of an anticonvulsant therapy, especially when other treatments are not producing the expected results. So this is something that, Ron, I may want to stop here and see if you have anything you'd like to add to this particular slide, because you've done so much work here.
Well, when we did our study, we found the prevalence rate in our population was about 40%. It was about 32% in children with ADHD that have this type of activity. And the sad thing is that when they normally start medicating children with autism, they start out with the stimulants for their ADHD symptoms. Then as they start getting anxious because their sleep is not doing well with the stimulants, they put them on an SSRI about middle school. And then when their behavior really goes over the top, they put them on antipsychotics at early high school. And this is all these medications make this activity worse. So it's why the difference in the numbers of the percentage prevalence rate has to be with the actual 70% came from the MEG studies, and that's not the type of EEGs we do. So you can find higher prevalence rate, but when we find it in our little 10 minutes of eyes open and 10 minutes of eyes closed routine EEG, then it's probably pretty serious. And we have found great results when we do stop the medications that are trying to make this activity worse and actually put them on an anticonvulsant. And we've had excellent results from that. There's a TED Talk years ago, if you guys are interested in that, from a lady that was at Harvard. It's an excellent presentation on the incidence and how a lot of children that are diagnosed with autism may not be autistic because of this activity. If you can clear this up, they lose the diagnosis. So just an interesting point, but I'll send that to anybody.
Yeah, excellent. Thank you.
There's,
So obviously the area of the brain where the focus of this unstable EEG activity is occurring is going to have an impact on how that shows up. So a lot of times it will appear left temporally where speech and language occur. Right hemisphere, there can be impairments with visual spatial or spatial motor tasks. More commonly, there can be memory deficits. There can be depression or behavioral issues. Obviously, when it's in the limbic area of the brain, there could be anxiety or panic attacks, or episodic behavioral dyscontrol. So a lot of times when we're seeing this instability, I'll be asking the parents, is this something that kind of comes out of nowhere, like a big storm, and then it goes away? and it comes and goes, because just like seizure activity is like this burst and then it's not there. And I'll say, can they be tired after it happens too? So if it's a really significant isolated epileptiform discharge, they could be having some kind of episodic dysregulation. And they could feel tired afterward, and they could be remorseful afterwards. They regret it. They don't understand why. They can't explain why they behaved the way they did. So if it's in the frontal lobes, we can see more violence happening. I had a little guy who was having some spiky stuff happening in his frontal lobes, and his mom would be like, yeah, we'll be out in public and we'll be in the grocery store, and he'll just reach out and pinch a stranger as they walk by. And he was adorable. She's like, everybody loves him. He's cute as could be, but he just has this impulsive need to he can't control his impulses. Any questions about paroxysmal EEG before we move on to the next pattern? All right. So next pattern we're going to talk about is mu. So mu is a wicket-shaped waveform. So, I have an example down here. They're different. I've heard different stories about how it got named or why it's called wicket-shaped. I've heard they named it wicket-shaped because it looks like a croquet wicket. So, which tells you the, social class of the people who were naming this. But it is a particular morphology or shape that we see in a specific, usually speed of brain waves and an area of the brain, typically the sensory motor rhythm, which is the area sort of where a headband sits on your head. So this waveform is something that about a little less than 20% of the average normal healthy population exhibits without any signs of autism, but it's much higher. It is exhibited in the autism population, maybe up to 70% compared to, again, that 20-ish% with a normal population. And again, I'm working on adjusting my language because I'm reading all this stuff about neurodiversity and versus pathology, and I know right now that the woman I'm consulting with who's a specialist in autism would be like, oh man, you're really pathologizing here. But I'll forgive myself being trained as a pathologist, basically. But so this mu activity doesn't necessarily, it's not diagnostic, it doesn't necessarily indicate that something is going on, but it could be that the mu activity is not turning on and off in the way that it always does with everyone. So we think mu has to do with our mirror neurons. So mirror neurons are a system in the brain that allow us to mimic, allow us to observe and then learn from observation and then be able to do that thing that we've just watched someone else do. With people who have mu that might not be activating and deactivating in a kind of more flow state way, there can be disruptions in that ability to observe behavior and then take that in and apply it to oneself and then act on that learning. So it's seen also at a much higher prevalence with ADHD, and you probably all know that that autism and ADHD communities very, very, very much overlap. So we do see this mu in much higher prevalence in both of those diagnostic categories. So the mu can also do with our ability to understand and mimic sounds and cadence. So it can be associated with emotional empathy, understanding, interpreting facial expressions, body language, understanding emotional content in language. So again, I exhibit mu and I don't have challenges with that, but just because you exhibit mu doesn't mean you have these things, but it's just something that we look for when we're doing the cues. Any questions about mu? All right. So next neuromarker that we look for are beta spindles. So obviously these patterns are not things that we just see in autism. So with these patterns, they supersede diagnostic categories. So we may see beta spindles in lots of different kinds of presentations with people, but beta is a very fast brainwave. It's associated with focused mental thought, but it can also be associated when it's in excess, when a person is not actively focused thinking. It can be associated with an irritable or easily kindled cortex. And basically, that just means that there's some level of almost like neuroinflammation could potentially be there. Something the brain is just ready to kind of have a burst of fast speed activity. This can result in sensory hypersensitivity when it involves the sensory areas of the brain. It can involve impulsivity and explosivity when seen frontally, especially on the right. OCD, anxiety, and over-focusing when we see it in the central midline, particularly in the front part of that, where the anterior cingulate is, which is a deeper midbrain structure that's responsible for our regulation of attention. So again, there's all this overlap with the parts of the brain involved in both ADHD and autism. So research has shown 50 to 60%, it's considered the most common subtype for all of these in autism. Any comments, Ron, on beta spindles?
Yeah, we're doing a study right now on the relationship of beta spindles, and we do feel we've got a good solid case. We're doing some pretty advanced level statistical analysis on that particular phenotype. And we find it is highly prevalent in those that especially have had brain injuries. We see a center that I do studies for a center up in Washington State that's all they refer us. And they have about an 80% prevalence rate of spindling excessive beta or beta spindles, as we compared to our normative, our 1,233 case archive had only a 31% prevalence rate. So it's pretty high. It's not just with autism, but it is highly correlated with anxiety and panic issues, and of course sleep issues and inability to inhibit actions. So that's why it's kind of connected to this group as well.
Yeah. Interestingly, it's also something that's seen in peak performers. So especially beta spindles at the vertex or kind of top center of the head. So there's a lot of neurofeedback that's done with professional athletes, Olympic athletes around the world. And we often see this kind of revved up brain. And often they're complaining of not being able to sleep well. And I work with some sports psychologists who work either with military or with high level sports folks. And I can't tell you, almost all of them say they don't sleep well. So they're revved up, and that can mean that they can respond really fast, and they have high energy, and they're motivated, and they have that Ferrari engine, but they also can't put it in park very easily sometimes. So next pattern we're going to talk about is coherence dysregulation. So coherence is a measure of intersite kind of how similar the activity is between two sites in the brain. So is the activity synced up together and moving at kind of the same time, or is it unrelated to each other in time? And so we really want all the different areas of the brain to be communicating with each other, exchanging information. We don't want them to be locked together so that they're kind of like all calling the same phone number and getting a busy signal. So we want them to be related, but not too related, not too unrelated. So when we have hyper connectivity, that's when parts of the brain are kind of too locked together. And that can create a kind of rigidity or an inability to tasks, to a rigid behavioral, actually, kind of expression. So we see that studies have shown in the autism community, it's much more common to have hyperconnectivity in the frontotemporal areas. As you can see in this map with all these red squiggles, kind of that point at the top of the circle is the nose. So we're looking down on the head from above, and we're seeing how the frontal lobes are all those sites where we picked up electrical activity. The red lines in between them are showing where the activity is too synchronized, is too locked together. And so the different parts of the brain are not efficiently communicating with each other in an independent way. We also see hypoconnectivity, and oftentimes we see a mixture, and then we just call it mixed coherence dysregulation. We'll see this hypoconnectivity from the frontal lobes, which are too locked together, not being connected enough with some of the other areas of the cortex. So we can see that in lots of different ways. We can see the coherence dysregulation show up. Again, very high level of the autistic population does exhibit some form of a coherence change. And again, they're looking at these other ways of imaging the brain, like MRIs and diffusion tensor imaging, which also suggests that there is this structural abnormal functional connectivity in autism. So white matter tracks are different, are thicker and more connected to in some ways, and thinner and less connected in other areas, and that's just correlating with what we're seeing in the EEG. So again, there have been quite a few studies about this, showing these connectivity changes. Any questions about coherence? Or Ron, do you have any comments?
No.
Okay.
Sure. Yeah, Jessica, we find that in these cases of autism, there's so many different things going on. It's hard to peel it down just to a few. The coherence issues, the lack of connectivity, they call it disconnection syndrome. And I think we can see that a lot in autistic children, not just in their brains, but in their behavior as well. So I think I don't know how many slides you have left, but we always like to leave a little time for questions and stuff like that. I know we gave a lot of technical information and everything else here.
We have 2 more slides.
Okay, great. Let's go for it.
So we'll go fast. I don't want to bog you guys down too much. So elevated delta and theta. So that's slow, sleepy activity we see. This is a pattern that we do see both in ADHD and in autism, where we see a prevalence of slower, sleepy activity. This is the type of pattern that classically responds to a stimulant medication, because we're waking up the parts of the brain that are needed to attend, to filter out extraneous information and focus on something. So again, this is these slow, sleepy brains often looks like a hyperactive, impulsive, or inattentive child. Hyperactivity can actually be the body trying to keep the brain awake by moving around. And then a lower voltage EEG is a pattern that we do see, and this can suggest a diffuse encephalopathy. This is why QEEGs are so valuable, not just this, but many reasons, but finding someone who is presenting with autistic symptoms, who is exhibiting a very quiet brain, a very kind of suppressed brain activity, and potentially that activity is quiet and it's slower than we want. That's a big concern, that then we're going to elevate that case to get functional testing, blood work. We're going to try to see, is there some toxic or metabolic reason that this is happening that needs to be addressed or can be supported with supplements, with diet changes, with other types of interventions beyond what we're doing with the neurofeedback, or in addition to the neurofeedback. This can be related to genetic mutations, myelination issues, inflammation and immune responses, gut biome changes. So this is 10% of cases, but super important to know if this is going on. This is a big indicator that there's an issue. So I'm not going to get into the case study. We're just going to take some time to talk.
This was amazing. A lot of really useful information.
I hope everybody else didn't their eyes didn't roll back in their head too badly.
Yeah, well, I remember when I started out as Dr. Ron's intern, and when I'm hearing about all of this stuff, it is just a lot of new words, a lot of information, and so it does take some time to process and let it sink in, for sure.
I did upload the site of that YouTube video that you could reference on that. That's a really good video. I think what we need to know, we actually published a study 4 or 5 years ago on using EEG and machine learning algorithms in order to identify the pattern that goes with autism. People often ask, why is the prevalence of autism seems to be increasing? And chemical exposure seems to be the underlying reason for that. In fact, in Lois Hole Hospital in Calgary, they're doing a study on the increase of autism since the wildfires started happening up there. And they're having a tremendous increase in children with autism being born. So they're working on different methods to try to improve the outcomes for the mothers and the babies. So it's just something we have in our world. I think it's going to be getting worse. I think it's there are valid diagnoses of autism, but I think a lot of kids that are getting the autistic diagnosis may be misdiagnosed. And I think that's something that we can sponge out. We cannot cure autism, but we've had children that come in with that diagnosis, and when they leave, they can't have that diagnosis anymore because you have to have a language issue, you have to have a social issue, and you have to have some sort of repetitive behavior to get the diagnosis. And that's neurological issues that we work on all the time. Hey, Steve, glad to see you can make it, buddy. Steve's from California. He's one of our brood as well.
Glad to be here. Sorry I came late. I couldn't find a link, so I'll have to catch up with your first part at another time. But you did a great job.
Oh, thank you.
Mrs. Yuri.
Mrs. I don't.
Mrs. It was really good and put things really concisely from what I can see.
Okay. Any questions from anybody else out there? Come on.
I just want to throw in, as long as I have the floor here. Sure. I think one of the other aspects has to do with the evolution of our species, in that, when I was a kid, they complained that kids spend too much time in front of a TV, but we still had more time to play. One of the things I witnessed in my suburban community is that a lot of kids they get whisked off after school to do all these extra things, even in sports. I mean, it's all good, but, the additional time with screens and, there have been research articles showing that, maybe we're turning people into autistic, automatons or something, because they're not having as much facial communication, as much playtime that just comes from creative playtime. Like when, I'd lay on my lawn in the summers with my friend and go, what do you want to do now? Oh, let's get the tape recorder and make a little, audio tape, or let's go play hide and seek, or let's get in trouble in some way. So kids are engaged less with that activity and more alone in a different kind of mental state.
Absolutely.
Yeah, I will say after COVID, I work with kids and teens, and a lot of them do say that coming out of COVID, they just feel like their social skills aren't as good. And then, there's lack of eye contact, more social anxiety, and still experiencing it, in 2024.
Yeah.
You want to tell them about our presentation coming up?
Yes. So while y'all are still processing all of that wonderful information, we'll go ahead and tell you about our next discussions with Dr. Ron. It's going to be on May 15th from 12 to 1 p.m. Central Time. And we plan on having a guest speaker, Dr. Rusty Turner. He does a lot of research into the EMF fields and how that impacts humans, and how addressing that issue with his clients has improved their well-being. And so it's going to be a very interesting topic because, you know, sometimes you bring this up and people, yeah, explain, you explain it.
Electromagnetic fields. And this is something that even these darn little things we call cell phones. You know, your mother, when we were growing up, I was at a time when microwaves didn't exist, so that's how old I am. But then we got microwaves, and they do not stand in front of the microwave, you'll fry your brain. Well, these are twice as bad as microwaves. And they say in the disclaimer in phones say, don't hold them to your ears. So this is a big deal right now. And we're having a lot of similar symptoms. And Dr. Turner, a neurologist, pediatric neurologist, who I've worked with for, well, like I say, met in 2014. He's on the World Health Organization panel for this EMF issue that we've got going on now. So, and did you know the most prevalent, the highest impact of EMF in any city is in hospitals and in airports? Did not know that. So if you go to a hospital, you're being bombarded with a lot of EMF that you wouldn't otherwise. So it's just interesting how much that it surrounds us and we don't even realize it. And especially in the children, it's causing all sorts of issues.
That is interesting. It makes me wonder if you looked at a nurse population, if they would have more like symptoms or exposure compared to others then.
I think they probably would, but especially the young, especially like mold toxicity is especially harmful to younger children. Their brains are developing so dramatically. So it's been a pretty quiet group out there.
I think I've heard this term before. It's sort of like standing in front of a fire hose. I'm kind of sitting here. I took the notes of each category, but boy, I've got to go back and really listen. It's fascinating, but it is complicated. And I think, like Alexander said, if you work in that field, it sort of gets to be, you know, a natural thing. But wow.
Well, I think what's important to come away with is that we can get a lot of information about what's going on in the brain functionally with a person that we may have. I have 15 different autistic clients and all their brains have something different going on. And, recently, like the little guys I'm seeing this afternoon, one of them, when we got back his EEG and Ron and Dr. Turner looked at it with me and they said, you know what? He needs an MRI. He is, and his mom had said, he's always gotten this autistic diagnosis, but I feel like there's something that's not right. And when you hear a mom say that, and she said that the second time they went in, that they didn't get the diagnosis the first time when he was 3, and then when he was 4, that the people that she got him assessed with said, well, what do you think? And so and when we saw that, they did get a sedated MRI done on him, which is a big deal. And it does take some effort to get that escalated to that point. He was found to have a cyst on his pituitary gland. And so there was something else going on and it looked like autism. But it was not. I mean, it was, because autism it's just a word that defines a cluster of symptoms. But he had something else going on, and we were able to kind of find that through these clues in the EEG. And it's things like that can be so valuable in helping a person to get well or to be able to have a longer, healthier, happier life through different kinds of interventions and monitoring of what's going on in their brain.
And it takes the guilt off the mother and off the child because they feel so guilty for these things, the exhibition of this prevalence of these behaviors. But it's a neurological issue causing psychological behavioral symptoms. And we got to make sure we identify what's causing these problems, not what we call it. It's not as important. So, and I think that was a great case where we just all looked at it and said, the mother's right. We got to listen to these mothers when they say they just don't feel like they've got a good diagnosis or something's missing. The mothers are always right.
Another example of a way that the brain quantitative EEG results can be helpful is especially with adult women who come in and have struggled with depression and have had difficult relationships. And then we do their Q and they have never, ever encountered anybody even whispering the word autism to them. And then if you can join with them, if you can ally with them and you can say, look, here's what's going on in your brain. And for women, these characteristics can show up differently. And if they can explore the idea that possibly what they've been experiencing that is autism, then that can change the way that they look at themselves and what they've experienced in their life. And it can be empowering, and it can make all these pieces fit together for them. And I think that's where I'm learning now with the these new books in the neurodiversity paradigm, and looking at autistic empowerment and people who are higher functioning. It's probably not a good word to use, higher functioning autistic people, and how they relate to being autistic. That can be incredibly empowering for them.
I think so too.
Jessica, I have a quick question. One thing that we see at the hub across the board with our 13-year-olds all the way up to 30 years old, anxiety. I mean, it's just a huge part of what they're experiencing and who they are. And we've even had some parents share with us sometimes that they don't even really think, like, for instance, you mentioned high functioning. Especially in that case, the parents feel sometimes that it really technically isn't autism, but it's severe anxiety because of the way they're acting and the behaviors with the quirkiness and kind of standing back and observing and not really engaging much, that so much of that is coming from anxiety. And I just wondered if you could comment on that piece.
Well, I mean, it's where we get into, does it matter what we call it? How do we help them to feel better? And for me, I always take, when people come in, I'm always like, have you been diagnosed? What are your labels? Do you identify with your labels? Do you agree with your labels? Are your labels, how does that help you navigate the world to have those labels? And whether we call it autism or whether we call it severe anxiety, what are we going to do with it? And I think that's why I love working with the Q, is because I can look at the brain patterns and I can say, okay, here's how you experience your brain, and here's how your family experiences your brain, basically. And then here's how it looks functionally. And how can we optimize that? So really, it is a level of peak performance, whether I'm working with an Olympic athlete or I'm working with an extremely anxious person. I'm trying to optimize their functioning. And for me, potato, tomato, we can call it whatever we want.
And Julie, the high anxiety piece, we found that the spindling excessive beta trait in these kids are through the roof. It's the #1 underlier of panic attacks. And if they're not sleeping well, they never wake rested. They've got that. It's likely they have those spindling excessive beta. We can test for it, and there actually are medication. There's one medication that they found to help. In December 22, they found guanfacine, the Intuitive, can absolutely help with that because it's a vasodilator and it brings in more oxygen. But the photobiomodulation, the neurofeedback, all help tremendously with that. And that anxiety piece is very treatable if you know what you're looking for. Normally on anxiety, they'll medicate it with an SSRI, and that is actually stimulating and makes it worse. So that's why if you have they get an SSRI, they're worse on that. Send them over to us, and we can look at that, at least identify it, and try to work with the docs to put something on that can help make them feel better, because it is a big deal. But you're right.
I want to mention that I do mostly psychotherapy in my practice, and some biofeedback, some neurofeedback. Soon will be virtual reality biofeedback, but that's another story. And Jessica, we got to talk about that one. Some good things coming up in May, actually, a release of a product. The one thing I want to say is my wife is also a psychotherapist. She doesn't do the same work as me, but we both work with couples a lot. And we often stumble in, we could just see the, autistic traits on people pretty easily when you work with people, just especially in relationship. And, the wife's, let's say that typically the wife's frustration of what's been known as Cassandra syndrome, where she's not believed, like the Greek goddess, the Greek gods in the story of Cassandra. So often when you can stumble in and introduce the idea that, you know, hey, maybe there's a test I'd like you to each take that's online, and that's the autism, what's it called? It's
Is it one of the self-tests?
yeah, Sacha
There's a
Baron
couple of
Cohen's
self-tests that are
cousin,
really
right?
good.
The Baron Cohen test. I just say, go take this thing, come back next week, you know, or maybe they'll take it in the office for each of them. And if one of them comes up on the spectrum, now it gives us something to talk about. And often we can teach, you know, listening skills and certain change of behaviors that really help the marriage. And, you know, as they create those new neural pathways of behavior.
All right, we expired our hour. Go ahead, Alexandra.
Thanks for that addition. I appreciate everyone for attending today and for contributing. We are going to have this recording on our YouTube by usually in like within 24 hours. And so you can keep an eye out for that. Scott should be sending that out after it gets published. Jessica just posted the website and the link, so grab that before we start to head off. But we appreciate everyone for coming. I hope you'll have a great day.
All right,
Thank
thanks,
you.
everybody.
Thank you so much.
Good to see you, Steve. We'll talk soon.
Okay. Bye-bye.
All right, bye-bye, guys.